I'm going to talk tonight about testosterone. Testosterone's been in the media quite a bit. There's a lot of information and misinformation about testosterone. I think it's a timely topic. I like these things to be kind of low-key, so if you have questions during, raise your hand and stop me and ask questions. I think it's the best way for everybody to learn about things. I learn just as much from your questions as everybody else in the audience. So please feel free to ask questions. There'll be a session afterwards as well. So in my practice, there's four of us, four urologists at Holland Hospital, and we all sort of divide things up, but we all have our little areas that we're interested in. Men's health is one of my concentrations, and a large part of my practice is testosterone and testosterone replacement. Tonight I'm going to talk about some of the things that are important about testosterone, and I can tell you that men with low testosterone really need to think about testosterone replacement because the side effects of low testosterone can be significant, and there's a potentially a big upside to testosterone replacement therapy. Testosterone replacement's important. Men with low testosterone who are symptomatic from low testosterone, I'm a big fan of replacement. I think testosterone replacement can be very important. And I think what's important is not only the replacement, but following patients who are on testosterone replacement. That's very important. And I think what's happening is that these somewhat fly-by-night testosterone replacement centers are popping up in strip malls, the Men's Health Clinic, that type of thing. And they're interested in getting you in there. They're interested in more your wallet than your health. So you got to be really careful when you're seeing somebody for testosterone replacement. It's a sticky subject, and I would caution people to be diligent about who they're seeing and who's treating them. So what are the issues in men's health in 2016 that's important? Certainly dietary and health maintenance. And I think a big part of what I do when I talk to patients about testosterone and testosterone replacement, as well as about erectile dysfunction and other parts of my urological practice, is health maintenance and dietary health. That's really important. Cardiovascular disease is a big topic. I mean, we've got a big cardiovascular center here now that we've partnered with Holland Hospital. Bone and joint health is obviously important. Prostate cancer is a huge issue. 28,000 men are going to die from prostate cancer this year. And that's the same as it was 20 years ago. So we need to do a better job of screening men and treating men. Benign prostatic disease, that's just difficulties urinating. Erectile dysfunction is important. Erectile dysfunction is a marker of vascular disease. You have erectile dysfunction, you have a higher risk of heart attack and stroke. We know that as a general statement. Testosterone here. And then kind of the business of medicine, outcomes versus fee-for-service. You know, traditionally we've been a fee-for-service healthcare system. When you come to see me, I do things to you and I get paid to do them. I don't necessarily get paid to make you or keep you healthy. And now outcomes are more important for me. I get now reimbursed and incentivized based on outcomes, and that's an important issue. So what's the big deal with testosterone? Testosterone has direct and indirect effects on every organ system in the male body. Testosterone can interact with all cells in the body. Hypogonadism, that's low testosterone, is a crucial factor in patients with chronic disease states. So when I talk about chronic disease states, I'm talking about diabetes, congestive heart failure, hypertension, prostate cancer, all of that. Those chronic disease states that are being managed, testosterone plays a role in. There's a shifting demographics. And what I mean by that is that 15,000 people are turning 65 in this country every day. So we're seeing this burgeoning population of men as they age. And what I've seen in 22 years of practice is that men, as they age, don't want to sit in front of a TV and put their feet up. They want to interact with people, they want to be active, they want to live their lives, they want to do things, they want to work, they want to be intimate, they want to maintain relationships, and that's an important aspect of things. So we're seeing more and more patients that are over 65 and are maybe a higher degree or more susceptible to low testosterone. We know that 5 million men are affected in the United States by low testosterone. That number's wrong. It's much more than 5 million. So now that we're talking about this disease process and talking about what the symptoms of low testosterone are, that number is going to increase significantly. There are huge potential benefits of treatment. What are the risks of testosterone replacement? That's an area that's garnered a lot of controversy. There was a paper in the Journal of the American Medical Association that came out that attracted a lot of interest and talked about increased risks of heart attack and stroke in men on testosterone replacement therapy. But if you drill down into the statistics actually would tell you just the opposite. 30 medical societies petitioned the Journal of the American Medical Association to retract that paper. Hasn't been done, but again, the risks are important. It's something that we need to talk about and discuss when I see patients with low testosterone and talk about treatment. So 4 to 5 million people have low testosterone, men, specifically what we're talking about. And again, this number's low, but only 5% of affected men are currently being treated. And that's not a good thing. Tonight, what I want to talk about is regulation and physiology of testosterone secretion. Where does testosterone come from? That's an important thing to understand. Testosterone deficiency in chronic disease states, and again, diabetes, high blood pressure, congestive heart failure, prostate cancer, those diseases that are managed on a regular basis. We're going to talk about testosterone and the metabolic syndrome, testosterone replacement in prostate cancer, testosterone replacement in the aging male, sexual function, and I'm going to touch on some replacement options as well. So this is how we get testosterone, how it's made in our body. It's made in a couple different places, but ultimately cholesterol is where testosterone comes from. And cholesterol gets converted to this and this and this and this and this, and there we get testosterone. This is a cascade of enzymes that does this. And then with this enzyme, we get the female hormone. So all men have some female hormone, all women have some male hormone. And both of those levels are important for their health as well. But that's the science of things. We know that testosterone is the primary circulating androgen. Androgen means it's a steroid that builds us up. It's supportive. It keeps us healthy, builds our muscles, and builds our bones, and builds our brains and other parts of our body. Simply stated, this is the baseline secretor. This comes from the hypothalamus, this compound right here called gonadotropin-releasing hormone. That creates secretion of luteinizing hormone from the pituitary. The Leydig cells are in the testicles, and those are what's stimulated to make testosterone. So that's how it's made. It's simple. The adrenal cortex, the adrenal gland is the little gland on top of the kidneys. We all have the adrenal glands, and those are important. You really can't live without your adrenal glands, or you can live with difficulty without your adrenal glands. 5% of our androgens come from the adrenal glands. We know that the secretion of testosterone is pulsatile. We get a kind of a burst in the morning, and there's a little bit of a burst in the afternoon as well. And that's, again, a supportive thing. Again, highest concentrations in the morning. And one thing we know about when we measure testosterone in the bloodstream, all the testosterone that we measure is not the same. So we have to know what we're measuring and interpreting things correctly. This is just another sort of a messy slide that talks about how things work. The hypothalamus secretes GnRH. That goes to the pituitary, which secretes luteinizing hormone, which goes to the testicles, and the Leydig cells then secrete testosterone. That's the basic science lesson of this. This, again, is another one of the basic science things that, you know, the basic science of this, it sounds complicated, but it is really fairly simple when you drill right down to it. So what happens is that testosterone circulates in our bloodstream, and it goes to a lot of different cells in our body. And those cells all have these receptors, these specific receptors for testosterone. The testosterone can latch onto this receptor. It then gets incorporated into this cell and modulates all this stuff that happens in cells. In cells of the bones, of the muscles, of the brain, of blood vessels, all over our body, testosterone has significant effects. And again, it's somewhat of a complicated process, but simplistically speaking, testosterone gets to cells in our body relatively easily and has effect on most cells. So what are the direct effects of testosterone? Muscle mass, it improves muscle mass. Bone formation, it helps us make sperm for reproduction. Sexual function. Also, testosterone gets converted to this thing called dihydrotestosterone, which is really, really important. That creates facial and body hair. It can, to some extent, create scalp hair loss and balding. Although this is all different in how testosterone gets converted to DHT from patient to patient. It can lead to certain types of prostate growth and function, and it can also support erectile function. It can also lead to some acne. Ultimately, testosterone, again, can get converted to the female estrogen-like component, estradiol, which is important for bone health, for high-density lipoproteins, which is the healthy cholesterol, which can have an impact on atherosclerosis. And estradiol also has some important issues with cognition and verbal fluency. So we can thank women, as men, we can thank women for their hormones that makes us smarter and more fluent. And it also prevents dementia and Alzheimer's in some respects, although that's a little bit more complicated. So testosterone gets made by the testicles after all this complicated stuff in the brain, and it's sitting there in our body. We know that there is both bound and unbound testosterone. Bound testosterone doesn't work. It's latched onto by other compounds that prevent it from doing the things it's doing. Unbound testosterone is the stuff that acts. It's the free testosterone, which we can measure. Unfortunately, the assays to measure free testosterone are difficult and expensive, and they're not always done correctly. So most of us are not a fan of looking at free testosterone. In certain academic centers, we can do that. But here, I don't look at free testosterone very often. If I want to look at it, it's more of a calculated number than a truly measured number. Sex hormone binding globulin and albumin both bind testosterone. When it's bound to the sex hormone binding globulin, most of that testosterone is absolutely unusable by the body. Albumin is a little less tightly bound, if you will. What we call bioavailable testosterone, that's the stuff that works, is the unbound plus the albumin bound. And again, the sex hormone binding globulin portion may prevent that testosterone from functioning correctly. So when I look at somebody the first time around, and I'll get into that, I look at total testosterone, just a baseline total testosterone, first thing in the morning, fasting from midnight the night before. That's the first screening test I get. But I don't get it in everybody. I don't just, every person that rolls through my door, I don't order a testosterone. I want to know if they have symptoms as well. And symptoms are an important part of the whole diagnosis. So this again sort of looks at testosterone. Only 2% of our testosterone is free and actively available. 60% is really tightly, we call covalently bound, and can't be used by the body. It can't be incorporated into those cells. It can't bind to those receptors and get sucked into the cells and used. 38% is albumin bound. In certain patients, the albumin concentration changes. It goes up and it goes down, and it can alter the amount of free testosterone or testosterone that's available to the body to function correctly. So measuring testosterone levels, this is what you just asked about. Timing is important. And I think timing is important from a consistency standpoint. So what the American Urological Association states, the American Association of Andrology, which is sort of an aging association, the Endocrine Society, they've all come up with these guidelines. So when I see someone who I think has low testosterone, I'm pretty adamant about making sure that we measure that first thing in the morning. That's before 9 o'clock, 7 to 9 o'clock in the morning, and fasting from midnight the night before. So that timing is important. And the total testosterone, again, may be affected by this sex hormone binding globulin. Again, there are these assays that can measure free testosterone and total testosterone, but not everybody has those assays available to them, so we have to have some sort of standard we go by. The Endocrine Society guidelines are the ones that we really look at, although the American Urological Association recently came up with their guidelines as well. So when I have somebody that comes into my office who I think has low testosterone, or they think has low testosterone, we've gone to, in some regard, this is a relatively new questionnaire that looks at evaluating men for low testosterone. It's called the Androgen Deficiency in Aging Male Questionnaire. And this is a series of 10 questions that patients are answering for us. These questionnaires are okay. One of the things that we like is objective evidence. So if I was seeing somebody with high blood pressure, I can measure their blood pressure, and I'm going to measure it, and that's going to give me a discrete, objective number. It's a little bit different with something like low testosterone. Low testosterone has these symptoms, and people interpret these symptoms differently. In addition, some patients have difficulty with these. Some patients, because of the printing may be too small, they may have some cognitive issues that they can't understand them. So we can't rely completely on this. And I do in some regard, but not in all patients. Most of what I get from a symptom standpoint are my direct questions with patients. So I don't even like the nurses to go in and talk to patients before I see them. Because I like to ask the patients and hear their first responses. That's the most sensitive way that I can get an idea of whether I think they're truly afflicted with hypogonadal symptoms. So these are okay, but they're not perfect. And blood tests are okay, but they're not perfect as well. If you look at most of the assays, if you got a total testosterone at Holland Hospital, they're going to tell you that the normal range is from about 180 to about 750. I don't use that. None of us who do testosterone replacement use that number. So it's there for their own medical legal purposes, but I don't use that typically. So let's look at the types and causes of low testosterone. The number one type is called primary hypogonadism, and that's testicular failure. For some reason, those Leydig cells in the testicles aren't making testosterone. And that can be due to infection, injury, surgery, blood flow, a variety of different things. But that's called primary hypogonadism. Secondary is either due to the hypothalamus or pituitary gland dysfunction. So that GnRH, that first signal that gets secreted by the hypothalamus, if that's not working correctly, then that's not going to signal the pituitary to signal the testicles to make testosterone. Likewise, if there is a pituitary dysfunction, if luteinizing hormone doesn't get secreted correctly, that's not going to signal the testicles, and that's called secondary hypogonadism. And that's why in some patients, I'll look at their pituitary gland more specifically, and occasionally I'll find pituitary disease and pituitary tumors and other things that are happening in the pituitary gland that need to be evaluated. Most often there is somewhat of a combined primary and secondary deficiency. There are also some unusual congenital, meaning born with issues and symptoms and abnormalities called Kallmann syndrome that can cause low testosterone. People are born with that. Those are a little bit tougher to pick out. So what does testosterone do? It provides male sexual function, and one of the most sensitive indicators of low testosterone when I'm talking to patients is their libido, their interest in intimacy. Men have a strong libido, and it's maintained for a long time. Men that come in and tell me that they're not interested in intimacy is a red flag that they have low testosterone. Anabolic, anything that's anabolic means building you up, building your muscles up, your brain, your bones, your blood vessels, things like that. Hematological effects, basically what that means is testosterone will interact with the bone marrow to make blood vessels. This is why the cyclists in the Tour de France have in the past abused testosterone. It increases their hemoglobin, their oxygen carrying capacity. Hemoglobin is normal at about 16 or 17. They'll get their hemoglobins up to 20 and 21 and 22 so they can carry more oxygen. It's against the rules, and it can have some detrimental effects like stroke, so it's a bad thing. Bone metabolism is, there's a huge burgeoning area of testosterone research looking at bone metabolism, because what happens as we age is that our bones get weaker. And what's happening in the population right now is people like to stay active. And hip fractures in people as they age can have a significant problem in their livelihood and their ability to function. Mood and cognitive effects. Mood and cognitive effects are very important when it comes to testosterone. That doesn't mean depression, but moodiness and a depressive mood is important. More importantly, I think, are some of these cognitive effects, our ability to do the crossword puzzles and function and read books that we want to read and maintain our brains in some regard. There are definitive insulin and cardiovascular effects that are moderated by testosterone. So, and we're talking, when we talk about insulin and cardiovascular effects, we're talking about diabetes, heart attack, and stroke. And that's a really important part of things. Actually, testosterone has somewhat of a vasodilatory effect, meaning that it dilates blood vessels. So one of the problems with heart attack and stroke is that you're losing blood flow. Stroke a little different. You can have different types of stroke, being a lack of blood flow or a bleed. But narrowing of blood vessels can be counteracted, which normally occurs as we age, and atherosclerosis and narrowing of those blood vessels, that can be offset by testosterone. And there is a defined vasodilatory effect. The blood vessels get bigger and flow better, blood flows better with testosterone replacement in men who have low testosterone. Yeah, the question is, you don't have to have low testosterone to have low blood flow. No, low blood flow can be a multifactorial thing and caused by a lot of different things. Testosterone may be part of that.
But could low blood flow cause the low testosterone?
Yeah, the question, low blood flow cause low testosterone? It could theoretically if it's blood flow to the testicles and you're not getting the blood flow you need. So yes, it could. Let's look at anabolic effects for a second. We know that testosterone increases lean body mass, meaning muscles and bones. We know that testosterone also decreases fat. We know that men have a tendency to gain weight here in the truncal obesity. Women are kind of the butt and the thighs. I'll see men who have that sort of characteristic appearance of that truncal obesity, and that can be a sign of low testosterone. We also know that testosterone is involved with this nastiness here, mesenchymal stem cell differentiation. Basically what that means is that it can intervene and interact with cells at their core, meaning there are cells in our body that can become a bunch of different things, really important cells in our body. And testosterone can have a very positive effect on those cells. And that may be related in some regard to certain types of cognitive deficits like dementia and Alzheimer's disease. The hematologic effects I talked about before. And again, testosterone can interact with the bone marrow to create healthy blood cells like hemoglobin. What we see is this abnormal elevation in blood cells, especially when we're replacing testosterone with an injection every 2 weeks. So we have to be cautious. In men who I'm treating with testosterone injections, I want to be careful and follow their hemoglobin level because occasionally I'll see some elevated levels that things need to be altered a little bit. Bone metabolism effects. There are multiple pathways with testosterone that affects bone mass and bone health. And again, as we age and as we're active, we're at higher risk of having issues like hip fractures, and that can create significant problems. We know that estradiol inhibits bone reabsorption. So estradiol comes from testosterone. You've got to have enough testosterone to have enough estradiol. And if it inhibits bone resorption, that just means their bones are healthier, generally speaking. There's been a couple of studies that have looked at estradiol levels in men who have had hip fractures. And generally speaking, there seems to be some lack of estradiol in those men. Again, this is that hip fracture risk and testosterone levels. So very important that I'm interacting with the orthopedic surgeons and talking to the orthopedic surgeons who are replacing hips in 80 and 90-year-old people. We want to make sure that they have good testosterone levels. I think that can be an adjunct to them healing correctly after hip replacement surgery. Again, the mood and cognition, I think, is really an important issue. We know that testosterone improves the positive issues with mood and reduces the negative. The effects on frank depression are unclear. There's some active research going on at the University of Michigan looking at depression, careful studies looking at depression and testosterone replacement. Again, cognition is another important thing and helps us live our lives and do the things we want to do as we age. To your question, a little bit, testosterone has a vasodilatory effect. It's like a calcium channel blocker. We use calcium channel blockers in patients with hypertension. The blood vessels are squeezing too much. We put them on a calcium channel blocker. We open up those blood vessels. We lower blood pressure. Well, testosterone has that same effect to some extent. And some more significant research is going into this as we speak as well. We know there's an inverse correlation between testosterone levels and cardiovascular risk. So as testosterone levels go down, the risk of heart attack and stroke goes up. We also know, like I said before, there's a similar inverse relationship between levels of testosterone and visceral fat. That's that truncal obesity. Testosterone levels go down, visceral fat goes up. There are larger population-based studies that are needed because both of these, this cardiovascular risk and this visceral fat, are impacted by so many different things that we need these larger population-based studies to sort of ferret things out and figure out what's more important and what's less important. There seems to be a growing body of evidence to support the notion that men with lower testosterone are at a more significant risk of cardiovascular disease. That's been a recent paper out of MD Anderson down in Texas, had some very good data supporting that. There's very few papers that would suggest the opposite. 2 papers in general that we know about. What about testosterone deficiency and chronic disease states? Again, the chronic disease states are common. Diabetes is a chronic disease state. Hypertension is a chronic disease state. Congestive heart failure is a chronic disease state. Certain types of pulmonary dysfunction. Prostate cancer is a chronic disease state. All of these are important when it comes to testosterone. And these are issues that we've come in contact with. So we know that in chronic disease states, testosterone can have a centrally mediated effect, so that these disease states will affect our brain, which leads to stress and malnutrition, use of drugs for pains, infections, and things like that. And these can all have direct effects on testosterone function and testosterone production. What about HIV and AIDS? Now, we don't see a lot of HIV and AIDS here, but it's a big topic elsewhere when you get to the bigger cities. We know that 50% of patients with HIV/AIDS have diminished testosterone levels. The reason I bring this up, though, is that HIV/AIDS is not dissimilar from other types of chronic disease states now. You know, we used to think of HIV/AIDS as being something that was relegated to a certain segment of the population and that was a fatal disease. It's not really. It's now a managed disease. It's a chronic disease. And it can mimic in some senses the chronic disease of diabetes. There's been some studies that look that they're very similar in many regards. And what we know is that patients with these chronic disease states are more prone to low testosterone levels, which has significant effects on their livelihood, their ability to be treated for these chronic disease states, and ultimately their mortality and their likelihood of dying. Malignancy is another chronic disease state. 50% of men treated for malignancies have low testosterone levels. So when we talk about men with lung cancer or prostate cancer or pancreatic cancer or colon cancer, I think it's really important that we look at their testosterone levels. You know, we used to say that if men have prostate cancer, they can't have testosterone replacement. It's a contraindication. And it even says that on a lot of the testosterone medications now. But I have a significant number of men who have prostate cancer who I'm giving testosterone to and are doing fine. Not everyone, but a significant portion of them. Men with malignancies, I think it's really important, and I've talked to my hematology oncology colleagues about this. I think it's really important that we look at these men and when we're talking about treating them, we don't just focus on their cancers, but we focus on their overall health. And part of that is their testosterone levels. Again, cardiovascular disease, there was a study done in the Netherlands that looked at low testosterone and aortic atherosclerosis. So the aorta is that big blood vessel that comes out of the heart and supplies blood to the rest of our body. This study showed definitively that men were much more prone to atherosclerosis or narrowing of that important blood vessel if their testosterone was lower. A similar study called the carotid artery study showed that narrowing of the carotid artery was much more common in men with lower testosterone levels. A narrowing of the carotid artery means you're at higher risk of stroke. We know that testosterone replacement therapy leads to a better exercise tolerance and healthier blood vessels. Testosterone replacement therapy improves the good cholesterol and it decreases the bad cholesterol. Bottom line, testosterone replacement therapy may be cardioprotective. It may prevent you from having heart attack and stroke. And again, I think that heart attack and stroke is a multifactorial thing. There's a lot of things that can play a role in it. Testosterone's a part of that, though. Yeah. The problem with narrowing of the carotid artery, you may have no symptoms until you have a stroke. And that's why regular health maintenance and keeping you healthy is important. You know, again, in the past, when I talked about how our healthcare system works, it's important. Now we're looking at outcomes. So you as a patient, if I'm your primary care physician, my job is it's much more important for me to keep you healthy because I'm going to be paid to keep you healthy. So looking at your carotid arteries, looking at your other blood vessels, I mean, you may not have any symptoms of carotid artery narrowing until you have a stroke. So it's important to look at patients as a whole. And it may be
hard. No indicator, there's no nothing.
There are, but they can be fairly subtle. So. Yeah, there's a lot of little things, but this again.
Well, that's what I was asking.
Yeah. Well, there's a ton of symptoms that you might have, but again, it's one of those things that your primary care physician is going to look at you sort of in the whole and figure out if you are at more risk for heart attack and stroke. So what about the metabolic syndrome? The metabolic syndrome is something that we're seeing much more commonly these days. And what metabolic syndrome is a combination of obesity, increased cholesterol and sugar, loss of the good cholesterol, high blood pressure, and low testosterone. So 25 years ago, there was no metabolic syndrome. Now there's a lot of patients that are defined as having this metabolic syndrome. And I see a lot of patients in my practice who I think have that syndrome. And those are patients that I key in on and talk to them about low testosterone levels. We know that they're, based on this Massachusetts male aging study, there's an increased risk of metabolic syndrome in men with low testosterone. So not the opposite. It's not that you have low testosterone and you have the metabolic syndrome. In Finland, men with low testosterone were at increased risk of this metabolic syndrome or diabetes. So multiple studies have documented benefits of testosterone replacement therapy in this patient population. What about prostate cancer? So prostate cancer is something that we as urologists see all the time and is really important to us. And this is really an important statement. This is Dr. Cully Carson from Duke University. There is currently no evidence that testosterone replacement therapy initiates prostate cancer or stimulated subclinical malignancy to become clinically evident. So what this means is that if you have low testosterone and I treat you, you're not going to get prostate cancer. That's what that means. And it means that I can give you testosterone replacement even if you have prostate cancer, whether it's been treated or not. And that's not in everybody. So what's happening in prostate cancer nowadays is that we understand that we overdiagnose and overtreat men with, as far as prostate cancer goes. So I have a lot of men who have been diagnosed with prostate cancer who have required no treatment. We're just following them. It's called active surveillance. Men in that who are with that diagnosis, who have low testosterone, it's reasonable to treat them. And I follow them carefully, but it is reasonable to treat them. What about prostate size and PSA? We know that as prostate size increases, it theoretically makes it more difficult for us to urinate. And that's a reasonable statement. We also know that testosterone can affect the PSA, the prostate-specific antigen, which is the blood test that we get to help us screen for prostate cancer. We know that testosterone replacement therapy might increase prostate size, but I would tell people, even with larger prostates who are more prone to urinary symptoms, it's okay to put you on testosterone replacement therapy and simply monitor things. It's rare that I would see an exacerbation of urinary issues in men with larger prostates who are on testosterone replacement therapy. We also need to make sure that we're following the PSAs in patients on testosterone replacement therapy. So this was a small study that was done. There were 10 patients who had their prostates removed for prostate cancer. They underwent testosterone replacement therapy. There was no change in their PSA, and there was a significant increase in their quality of life. So that's important. Again, I think there's a myth about prostate cancer and testosterone replacement therapy. It's interesting, if you look back in the history of prostate cancer, there was a physician back in Chicago in the 30s that was a candidate for the Nobel Prize on a number of occasions, who showed that we could take testosterone away from men, and they thought that that would cure prostate cancer. We know that doesn't happen nowadays. But now the pendulum is swinging the opposite way. We're understanding that even if you have prostate cancer, we can replace your testosterone safely. So after prostate removal, we know that we follow patients very carefully with PSAs and regular rectal exams. We know that we treat testosterone replacement therapy in these men with the least amount of drug that ameliorates their symptoms, that treats their symptoms. And we know that these patients must have symptoms of low testosterone. So just because your testosterone is low, if you aren't symptomatic, that doesn't mandate treatment. But we need 5,000 prostate cancer patients followed for 3 to 5 years to accurately answer all of these questions. Fortunately, there's a big study going on through the University of Michigan that's gathering all the urology practices together in the state of Michigan, and we're combining all of our patients. So we're getting this data as we speak, and we're going to have more confirmed data on this. I would still tell you I have no qualms treating patients with a history of prostate cancer with testosterone replacement therapy. So bottom line, most epidemiologic studies suggest there's no association between testosterone levels and the incidence of prostate cancer. I will tell you, though, that I do think that at the time of diagnosis in patients, if their testosterone is abnormally low, they have riskier prostate cancer. And most of us believe that nowadays. And it has to do with how prostate cancer grows and develops. And if it can grow and develop without testosterone around, it's probably a more virulent disease. So what about the aging male? 5 million men in the United States are hypogonadal or have low testosterone, but only, again, 5% are receiving replacement therapy. From my standpoint and from all of our standpoints in urology, we're much more tuned in to identifying these patients with low testosterone and really focusing on treating them because, I think their quality of life can increase significantly. We know that testosterone secretion decreases with age. The short-term consequences of that are lack of interest in sex and depressive mood. Depression is probably the wrong word here. The longer-term consequences, bone loss, muscle mass issues, and cardiovascular risks. And again, there's this baby boomer population, which is really a burgeoning part of the population that we're seeing nowadays. And our practice volumes are increasing immensely. And very much so. So there's been a couple of good studies that have looked at, the question is, can testosterone replacement therapy reverse bone loss? So there's been a couple of interesting studies that have been done that have measured bone loss with certain types of X-rays. And these have been very sensitive X-rays to the quality of the bones in patients with low testosterone. And these men have been on a very strict regimen of testosterone replacement therapy, and they've been re-imaged. And the quality of their bones based on these imaging studies have improved significantly. So that just means that they have healthier bones, less risk of fracture. And one of the studies was done primarily in patients with malignancy who are at higher risk of bone loss because of the effects of chemotherapy. So it's a good question. The question is, would the same thing be the case with arthritis? Nobody knows that. Logically, I would tell you that certain types of arthritic changes may be lessened with testosterone replacement therapy in patients who are hypogonadal, but those studies have not been done. There's a big push into that simply because of the amount of people that have been operated on for different types of arthritic issues in joints and in their back. And there's a study going on at UCLA in Los Angeles looking at patients who have had back surgery for chronic back pain and have low testosterone. And are there ways that we can see better outcomes in these back patient surgery patients? So that's a good question. The question is, why aren't PCPs more tuned into screening for testosterone? I'll defend them a little bit, and I'll tell you that I think that they're as busy as they can be. Their plates are stacked. My preference would be that they talk to patients about low testosterone and send them to me. That would be the way to go. And not from a monetary standpoint, because I'm as busy as I can be right now. But I have a focus on this, and I think I can better evaluate and treat these patients. I think they're going to focus on the things that are more crucial, your diabetes and your blood pressure and your cholesterol. But they have so many things to look at on a daily basis with every patient that there's a point in time where things become somewhat limited. And I think it's also, if you look at the Affordable Care Act and what the Affordable Care Act is doing, I would defend the Affordable Care Act in some regard, in that I think the push there is to look at outcomes. So right now, nobody looks at my outcomes at all. If you come to me and I operate on you, I get paid to operate on you. Nobody looks at my outcomes. That's changing. The primary care physicians are now being more graded on their outcomes, more stringently. Well, and again, what I think is really important is that you need to be your own advocate. And you need to push the buttons and say, I need this. Unfortunately, the healthcare system is what it is. It's going through these big changes right now. I think a lot of the changes are good. Some of the changes are not good. But keeping patients healthier is the point of things. It should be the point of things. Fee-for-service medicine, which is what we've had forever, really didn't matter. It wasn't focused on keeping patients healthy. I think that's changing. Yeah, again, I think the PCPs do a really, really good job. I think they're as busy as can be. Again, we're trying to set up a system in Holland where we have this integrated healthcare system where I collaborate with my primary care colleagues and with the cardiologists and with the endocrinologists and with the cardiovascular surgeons and the orthopedic surgeons to keep people healthy. That's our charge. That's what we should be out here for. That's why I'm standing up here. I mean, I don't get paid to stand up here and talk. I think this is an important message to the community, that people understand stuff like this. It sounds complicated. It really isn't complicated, but ultimately it can go a long way to keeping us healthy. I mean, I'm aging too, so I want to keep myself healthy. I want my family to be healthy. We are. We
You're not just catching on to it, or?
No, I think, again, I think a big part of this is the primary care physicians doing what prioritizing things and doing the things that are important for them. They can't do everything. There's also a lot of misinformation about testosterone. There's a lot of primary care physicians that think it's a bunch of nonsense. And I don't believe that at all. And that is still being sorted out, to be honest with you. I'm a big proponent of it. I think it can keep us healthy, and it's a very important thing to look at. As my wife would say, doctors are occasionally right but never unsure. And that's how we are. We think we know everything, and we don't know everything. And sometimes a little humility goes a long way. So, those are good questions. Keep going here. So, why do only 5% of hypogonadal men receive testosterone replacement therapy? So this is sort of a timely slide. So we like to blame the patients. I hate going to the doctor. But the patients are part of the issue. Doctors are part of the issue. Symptoms are a normal part of aging. That's doctors. I think that's what was said to you, right? Incorrectly assessed or not assessed at all. Again, we get the testosterone level drawn at Holland Hospital, and the printout comes and it says the normal range is 180 to 700, and your testosterone comes back at 200. Well, that's normal. No, it's not. Less than 300 is abnormal. So there's got to be some consistency there. There are perceived risks of testosterone replacement therapy, prostate problems, and these cardiovascular things that, again, if I can give you a stack of papers this high that would support, these are peer-reviewed academic papers that would support testosterone replacement therapy, looking at things like cardiovascular disease. There are 2 papers that say the opposite. One is from the VA, and that should tell you enough. The VA paper was a monstrous joke. There were women involved in this testosterone replacement therapy that never got testosterone. There were patients that had never filled their prescriptions. It was really a bad study. The other one I referenced earlier at the Journal of the American Medical Association. So let's talk about treatment. What are the goals? The goals are all of these things: improve libido, mood, feelings of well-being, muscle mass, bone, cardioprotective, contraindications. We talk about breast and prostate cancer. You know, large prostates, sleep apnea, congestive heart failure. This is probably the only thing that, from my standpoint, is a contraindication to giving testosterone replacement, and that is an elevated blood count. That hemoglobin level is too high. I think there's good studies that show that sleep apnea is improved with testosterone replacement therapy. I rarely see prostate problems, urinary problems in men who are on testosterone replacement therapy. Obviously breast cancer doesn't occur in men or occurs rarely. Prostate cancer is not a contraindication in my mind to replacing testosterone, without a doubt. Let's just focus on sexual function. It's a difficult subject for some people to talk about, but it's something that I think is really important. Again, I would tell you that there's many good studies that show that men with erectile dysfunction are at higher risk of heart attack and stroke. I wrote a paper once that said erectile dysfunction can save your life, and it can. And I've had patients who come into me for erectile dysfunction who we've diagnosed significant heart disease on. What are the facts? We know that lower testosterone levels diminish interest in sex, libido, diminish spontaneous erections. Those morning erections and night erections that we get are very important to keeping things healthy. They're really important. Loss of those erections can lead to significant problems. We know that testosterone replacement therapy has central and peripheral effects in our body as far as sexual function goes. We know that in testosterone replacement therapy, there's an increased frequency of sexual thoughts and desires, and that's a normal part of things. All of this stuff is in some regard, is positive and good when it comes to testosterone replacement therapy and sexual function. One myth, though: testosterone replacement therapy is a primary form of treating erectile dysfunction. It's not. It's a supplement in some regard, but it's not a primary therapy. Things like Viagra and Levitra and Cialis and injection therapy and penile implants are primary therapies. Testosterone is not. Let's go over this one. That one. So let's look at testosterone replacement options. These are the options you've come to me, we've talked about your testosterone, you've got symptoms of low testosterone. We measured your levels, they're low. We figured that you had sort of this combination of a pituitary problem and a testicular problem, and we're going to talk about testosterone replacement therapy. Right now, a lot of testosterone replacement therapy is governed by the insurance companies. The insurance companies are going to tell us what we can and cannot do. That's somewhat of a reality because they're going to pay for things. I think that the transdermal gels, so this is a tube of a gel that you can rub on your shoulder or chest, your inner thigh, or under your arm on a daily basis. I think that's the most physiologically normal way to replace testosterone. You got to do it every day. You can get it on your partner, which you don't want. The insurance companies don't pay for this, and the pharmaceuticals know it, and they've jacked the price up, and it's exorbitant. So what happens is that everybody really starts off with injection therapy. So you get a shot in the butt every 2 weeks. And what I do is I have you get these shots every 2 weeks over the course of about 10 weeks. And then we recheck your levels 1 week after an injection, halfway between. It's really important to do it that way. And in time for your 6th injection, you come back and we talk about your symptom response, and I look at your laboratory responses. I look at your testosterone, your PSA blood tests, and your hemoglobin. And that's how we start out in most patients. Transdermal patches, these are these patches that we put on people. Those have fallen by the wayside. People get these welts and they look like they've been attacked by an octopus. They itch and they're really a problem. So I'm gonna go back. Buccal discs. This is a little, it almost looks like a little piece of cardboard that you put on your gum, and the testosterone is absorbed. The majority of those patients ended up with significant gum irritation, and nobody uses those anymore. Oral preparations are a no-no. You can get them elsewhere in the world, but what happens is that they get transformed, these medications that you take orally, you swallow, they get transformed by your liver and they create liver tumors. And that's a problem. The subcutaneous pellets are a reasonable option. That's where I put a series of pellets underneath the skin on your buttock. It takes about 5 minutes to do it, and it can last 6 to 9 months. There is a newer injection in the United States now. The standard injection lasts 2 weeks. There's a newer injection that lasts 10 weeks. It's been around in Europe and Canada for 25 years. All of my Canadian and European colleagues, when I go to meetings and talk to them, they all use the 10-week injection. It's not well thought of here. When the FDA approved it, they approved it at a lower dose. I've had a number of patients that have been on the medication and they don't respond very well to it. So it's not a great option, unfortunately. So I went through all of those. This is the every 2-week injection that we use most. Probably about 75% of the patients in my practice are treated with this. I can teach them to inject themselves at home. We still have to monitor them carefully though, and they've got to get regular blood tests. A lot of patients will come in and they don't want to do it on their own. They'll come in and get that done in the office. This is not approved in the United States. It can be used in Europe and Canada. This is the longer acting substance, which again is a good option. Unfortunately, it's at a suboptimal dose. Again, these are the patches that we don't use anymore. The gels, I think, are the best option, but they're very expensive, very, very expensive. The buccal discs I talked about, the Testapel or the subcutaneous pellets. So kind of wrapping things up here, I know that we've gone a little bit longer. We know that testosterone is the primary male androgen. The androgen is the thing that builds us up. We know that low testosterone, hypogonadism, is a very prevalent issue. 5 million people are affected. It's probably triple that, to be honest with you, I think, or even more. Short and long-term effects of low testosterone can be significant. The assessment, very straightforward. Treatments are varied, and again, very straightforward. There's a lot of different options for treatments. And right now, I would tell you that without a doubt, treatments have very acceptable risks, and the upside of treating patients significantly is greater than the downside risk. And probably there's a bigger downside risk to not being treated. I'm more than happy to answer questions. I'm going to stand up here for a little bit. I appreciate everybody's attention, and I appreciate the questions, and hopefully this has helped you with some issues with low testosterone. Yeah, you do. This is just a replacement therapy. And again, I think there's a lot of research going on into better options for longer-term replacement therapy, so you don't have to come in every 2 weeks. You know, one of the problems with the every 2-week injection is you get a big burst of testosterone and it trickles down over 2 weeks. It doesn't really do that. It's a little bit different. But that's not a physiologic way that testosterone is released in our body. Remember, we get a little bit of a burst in the morning and it trickles down over the day. That's why the gels are a better way to go. But you got to put it on every day. And you can, there is transference. If you don't rub it in and you put it on before you go to bed and you're hugging your wife, she could wake up with a mustache. Kind of. So, yeah.
Do the pellets need as much follow-up as the injections?
Yeah, the pellets are a little bit different. I like the pellets. I don't think there's as vigorous a response to the pellets as there are to the every 2-week injection. I think people get a more vigorous, good feeling with the injections. But the nice thing about the pellets, if you reach a steady state on the pellets, and we know that let's say you're an every 9-month pellet person. I have a lot of patients like that. I see them every 9 months, and I get a blood test essentially a couple of months before they come in. And I know where they're at, and it's pretty easy. So it's easy to follow, yeah. It's not going to come down for a while. The pharmaceuticals know that I'm out there doing this. They like this because I'm talking about this stuff that they make. I don't have any association with any of the pharmaceuticals. I don't talk for them. I don't like to see them in my office, to be honest with you. I think they're on the one hand salespeople, but they provide an important service. It's just that they're very much into a profit motive. And when they see things like this, they jack the prices up, and they're expensive. It's not coming down anytime soon. The other thing, though, there are compounding pharmacies that are starting to come out with a cheaper version of the topicals that they make themselves. There are some issues with compounding pharmacies and safety with some infections that occurred in the past. So some of the compounding pharmacies went away. But some of the compounding formulations can be, we could see a rise in those in the market. Yeah.
Perrigo has a generic tester.
Yeah.
A lot cheaper.
Yeah, absolutely. Perrigo is one of them, and Perrigo does, I think, a good job with some of the generic stuff. So, yeah. Again, I can give you a stack of papers this high that would say just the opposite. There are 2 papers that would suggest you're at higher risk of heart attack and stroke with testosterone replacement. And both of those papers are remarkably poorly put together. So I'm a proponent of it.
And my insurance used to cover it. That was prior to where we're at now.
Yeah, Blue Cross Blue Shield made some changes, but what the insurance companies do is they make some changes, and they make it a little bit more difficult, and a lot of physicians and patients kind of give up. When your payer says no, we say okay. But if they say no and we say, wait a minute, we send letters and we bug them, they'll say yes.
Like my next.
It's a good question. Yeah, I think there is. The problem is that there are no studies that would confirm that. And with all the natural supplements, the studies haven't been done. And so you don't really know. And I wouldn't say, no, you shouldn't do that. I would say to you, the only downside of doing it is your out-of-pocket costs, and you're guessing. So, yeah, it's a great question. I have a lot of patients that get medications from the Canadian pharmacies. And most of the patients that I see that do that are patients looking for things like Viagra and Levitra and Cialis. I have rarely had patients have problems with those pharmacies and those pharmaceuticals. Yeah, again, there are no studies that would show that to be effective, or is there any proof of its efficacy? But I do think there are some natural benefits that we can get from those remedies. It's just that there's no studies that would confirm or support those.
Is there a certain type of food you can eat?
Well, I would tell you that, one of the things that we need a well-balanced diet. Cholesterol is the building block of testosterone. So you need cholesterol. Cholesterol is an important substance in our body. Fresh food is really important. I think processed food's a really bad thing. I think foods with high fructose corn syrup and those simple sugars are bad. Those are the things that stimulate our pancreas and create pancreatic problems and diabetes and fat-related issues. That's more important, I think, and ultimately that's going to have some impact on testosterone production. No, it won't lower your testosterone. No, because there is, and I think that's a good question. You need a certain amount of cholesterol to build and to make testosterone, but you will have that regardless of how low your cholesterol goes. So, no, you didn't. Calcium being bad for you?
Calcium blocking?
No, what I think what you're referring to is that testosterone, it can act in some regard like a calcium channel blocker. So calcium channel blockers are given for people with higher blood pressure and certain types of heart problems. It increases blood flow because it can allow more blood to get to certain organs. And testosterone has a similar effect on the blood vessels as do calcium channel blockers. Yeah, Medicare is the same thing. Medicare is restrictive, and Medicare and supplemental Medicares are restrictive. Most of the Medicare patients are not going to be able to qualify for the topical agents if you're referring to treatment. Yeah, treatment. Most of my Medicare patients are being treated with the every 2-week injection. So, yeah, insurances can be fickle though, and they can have little things that they exclude. So you have to be very careful when you have your insurance policy. You have to know what's covered and what's not covered. But I fight with the insurance companies all the time regarding a bunch of different things. And I have all these form letters that we just type out and sign, and we badger them. And I call Priority Health all the time. I know the medical directors there. I'm sure they roll their eyes when they see me on the phone. And it's not, I'm not nasty about it. It's just, it's sort of like the squeaky wheel. If you're firm and dispassionate, you can get things done. It's a time-consuming issue, I think, in many cases. Depends on him. I think there's some primary care guys that like to stay in control and do things, and I'm very supportive of that. Likewise, I'm supportive of those that say, I'm going to take care of your diabetes and your high blood pressure and your heart disease and your cholesterol, and I'm going to let Ludlow do the testosterone stuff. No, once a month is wrong. Yeah, I see that a lot. Once a month injection of the testosterone cypionate is not adequate. You'll get a blood test at 2 weeks and you'll be completely low. So it's now, and I'll step back a second, and I would tell you that as soon as I say that will always happen or never happen, I'm wrong. There are some patients out there that probably function fine on a monthly injection. I have a couple guys on a monthly injection. But the vast majority of patients need it every 2 weeks. And I can show you, I can show you the data. I can show you the data from my patients to prove that. So you don't. You can call the office, and that's the nice thing about healthcare nowadays. You don't need referrals. You shouldn't. If you want to come in and see us, we're more than happy to see you.
I hate to ask, how long is the wait?
It's not that long. Our goal, there's 4 of us in this group. Now, I do most of the testosterone stuff comes to me, but our goal is not to have people waiting 6 weeks to see us. Our goal is to see patients promptly, and we're pretty good at doing that. And if things happen and you need to be seen, be the squeaky wheel. Just come in and we'll get you in. Nobody has to wait a long time. Well, if I saw you today and we talked about low testosterone, I thought you had symptoms of that, I would get a blood test tomorrow morning, theoretically. That comes back in 24 hours. the guidelines are pretty strict about saying if your testosterone comes back less than 300, we need to confirm it with a second. And the insurance companies are sticklers when it comes to that. So what I do, if let's say your testosterone came back at 220, I would have you a few days later get a second testosterone and a luteinizing hormone. It tells me what type of low testosterone you have. And theoretically, the next day we could treat you. I mean, you can do this in less than a week. It's pretty quick. Yeah, that's a good question. So what happens when you get exogenous testosterone, meaning you get a shot in the butt or you get the gel or the pellets? What that does is it sends a signal to the pituitary gland to decrease the luteinizing hormone. Remember, the luteinizing hormone is the thing that goes to the testicles and says, make testosterone. So that gets suppressed. There's a small percentage of patients where that suppression will be long-lasting. So that once you stop the exogenous testosterone, there is the chance that your normal level of testosterone or your typical level of testosterone won't come back. That happens relatively infrequently, but it can happen. There's also an option, for instance, if I have a 25-year-old who has low testosterone for whatever reason, I won't treat them with exogenous testosterone. I'll treat them with a substance that stimulates their pituitary called Clomid. And that's always an option. I didn't include that up here, but that's always an option. That maintains sperm function and production, and all it does is stimulate the testicles. But it really has to be somebody that has a primary hypogonadal diagnosis. So that's something I always talk to patients about. It's an important adjunct to things. No.
Thing that
That's a physiological.
I don't want to do this anymore.
Yeah, your libido, right. You know, men have a strong libido. We know that. Men are raring to go. And that's a reflection of their testosterone. And libido is one of the most sensitive indicators of a low testosterone. When I have men that come in and I ask them specifically, are you interested in intimacy? And they say, well, kind of. That's a red flag right there. Sometimes you have to dig into that a little bit more too to figure that out, because there can be some other psychosocial issues going on and relationship issues. And when I see patients with sexual dysfunction, whatever it may be, my preference is to see couples, because I think all of that is a couples issue. And it's much more effective in me from the standpoint of evaluating patients correctly and treating patients correctly to see both partners. It works much better that way. You know, it can be a sensitive emotional issue. Not many people like to talk about it. I see a lot of patients with sexual dysfunction. You know, what I would tell you is that we want to live our lives. People want to maintain their intimacy. They want to do the things they want to do. They don't want to say, well, I'm 65 years old, I'm done. That mindset is falling by the wayside. So.
One or two more questions if anybody has them.
Anything else? Well, thanks everybody for coming. I appreciate it. And if you have questions, you can always call the office. I'll talk to you over the phone if you have questions about something. You don't need to be a patient. If you have a question about something, leave your name and number in the office. I'll phone you back. It's a good, you know, one of the great things about Holland, I spent a lot of time in Grand Rapids, 15 years in Grand Rapids at Spectrum. Holland does a really, really good job. It's a smaller hospital. I think it really appeals to the community, and our goal is to keep the community healthy. So thanks everybody for coming. Appreciate it. Thank you.